Welcome to another episode of 22 at the Lips. This is the podcast hosted by yours truly, Alexis Hardwick. And this is the podcast from EMS providers to EMS providers and healthcare providers and anybody and everybody in between. Whether you work on the ambulance, you work in a hospital setting, or you work in an office setting and you stumbled upon this podcast, you are invited. We appreciate you. Thank you so much for joining us on this journey. So, and as my guest and I talked about today, it's Jeff, not Geoff. But since Jeff started sponsoring the podcast, Geoff, since Master Your Medic started sponsoring the podcast, I've had incredible opportunities to meet a variety of people. And one of those today is Mike. I'm going to do what he told me. Add the Italian hand, Turconi. I know I butchered it. I'm sorry.
No, that was actually good.
You can't tell, Mike he has an Italian accent. It's not super strong. You might miss it, but it's there. But our topic today, I think, it's not one of the ones that's near and dear to my heart, but there's a lot of aspects that need to be, I feel like, addressed in EMS, and especially if you're a new provider. This topic, trauma codes, it kind of wrecked my world a little bit because it's so different from our regular cardiac arrest algorithm, in my opinion, in some ways and others, but we're going to get into that. However, first, Mike, if you want to tell the people who you are, what you stand for, the floor is yours, my guy.
All right. Well, since my accent is really slight and imperceptible, I feel the need to specify that I'm originally Italian in case you missed that. I started my journey into paramedicine, pre-hospital medicine, whatever you want to call it. In 2015, I was a special operations combat medic in the Italian Army for a little bit. And then I got out, moved to Canada, and transitioned into a civilian paramedicine career. Did some time on ground ambulance and switched to flight in 2022. And parallel to that, I do a bunch of other stuff in education with police and military, tactical medicine here in Canada, back in Europe. And I've been doing humanitarian work for the last year and a half in primarily in Ukraine with a couple of different NGOs. And I'm a trauma junkie, so this is a topic that's very near and dear to my heart. And thank you very much, Alexis, for getting me on, and to Geoff at Master Your Medics for sponsoring this podcast. He's gonna hate it. He's gonna hate it.
I'm gonna get a text message. It's gonna be like a write-up or something like that. Pay a fine for every time we say Geoff. It's 25 cents because we're all broke. But yeah, so unlike Mike, I am not a fan of trauma. How that works as a paramedic, I have no clue still. I can handle the blood and the guts and the gore, all that stuff, but I'll be honest, if I start bleeding or something like that, I freeze a little bit because I'm like, oh no, this is not good. I'm not a fan of it, but I can handle it. The blood, the broken bones, the mangled things, I'm not impressed. But yeah, so especially one of the things you learn in paramedic school, you have your medical calls and your trauma calls, and your workups, your assessments, all of those things, they're the same, but the rate of which you do it and the order of which you do things can kind of vary depending on your general sick or not sick, because there are so many things going on. And recently, as I explained to one of our patients, this guy who fell off of a roof, not because he's hanging Christmas lights, he lost his drone on his roof, and he climbed up a ladder to go and find it, but then decided the best thing for him to do would not be to climb down the ladder in case he fell off the roof. It would be to jump from the ladder. which resulted in two very compounded, fractured, and messed up feet and a fractured tibia. And so,
Yeah, that would do it.
as one does. But yeah, he's sitting on his porch. When I asked him, I was like, "How did you get from the ground to your porch?" He's like, "I just kind of climbed up using my arms." I was like, "Okay, my guy." And he's like, "Oh, I thought about jumping from the roof, which is like, or jumping from the tree, which is right next to his house." And I was like, "Thank you for not." But yeah, he was like, I can just, I can kind of hobble to the stretcher. Y'all don't worry about it. I was like, here's the thing. I know you feel fine right now because you took your Clonopin like right before this. I was like, I know you feel fine. However, there could be so many other things going on that you do not feel because your adrenaline is kicking. And I've seen on like a motorcycle wreck, this guy, he's up, he's walking around, he's totally fine. However, he's internally bleeding. He had a lot going on. And that's the thing of like these trauma calls. It's even though anyways, I'm not going to get into a whole thing, but just because you have your distracting injury doesn't mean that's the only thing going on. Anyways, so with all of that in mind, trauma calls are a little different from medical calls. One of those various aspects are your trauma codes. And it's pushed so heavily. And I feel like in light of recent events with that football player, I don't sports, the football player who went into cardiac arrest on the field. I feel like ever since then, it's kind of being brought more so to light to the public, but also highlighted even more so in the field. On a cardiac arrest, you stay and play. But then you have your trauma codes. You do not stay and play. You load and go immediately because even though paramedics call themselves, I don't, ditch doctors and an ER on wheels, I don't know who you are and what system you run in. We do not do surgery in the back of the ambulance. I don't crack ribs and manually pump the heart with my hands, but there's a lot of things that have to go on and things that get put into motion. Um, a lot of that is also, I feel like, not just getting like a medical history, if you even have anybody who knows the medical history, but like on a cardiac arrest, you start your stuff, you talk to the family or whoever's there, and you try to get an understanding of what kind of medical history does this patient have. And a trauma code, you're lucky if you get a name. Um, you're lucky if you get a date of birth. Everybody's John Doe because it's normally situations that all these people get themselves in. Anyways, so it's also like for your regular cardiac arrest, you get there, you work it, you do what you got to do, you get ROSC or you don't. And if you get ROSC, you transport. If not, whatever. But trauma codes, your main priority is to go. But it's also a matter of making sure you when you get to the ER, you tell them like this is how it started. This is what we saw. This is what could have possibly happened. This is, the card looked like this or whatever it is. Yeah. So, Mike, since trauma is your thing, please tell us why do we load and go and administer boluses of diesel fluid versus staying and playing like a regular cardiac arrest?
Oh, that load and go and diesel bolus was so cringe. That resumed 50 year of culture that we need to change in EMS. No, I don't think that we should neither stay and play nor load and go. I think that when it comes to trauma codes, the name of the game is to fix and go, because we'll get into that. But there are certain things that we can definitely influence in the pre-hospital phase, and that we are in the position, we are in the optimal position to address in a timely fashion, in a way that the staff inside the hospital, will never be, just because of, unless obviously the trauma codes happens in hospital. But for pre-hospital trauma codes, we are optimally positioned to immediately address some of the potentially reversible causes. So fix and go is what I think should be our mantra. But the biggest thing is that you hit the nail on the head. It's a completely different beast compared to a medical cardiac arrest. And one of the biggest differences is that when you have a medical cardiac arrest, talking about our ACLS algorithm, you typically fall into the VF or the VT branch, and those are what we call no flow states. So the art is not generating any output. When it comes to trauma codes, most of the time, what you're looking at is not a true cardiac arrest, but is an extremely low flow state that results in the generation of no output. So you do have a heart that's trying to generate a beat, and in fact, you're most of the time in the PA branch, but either because of hypovolemia or because of an obstructive mechanism, there is actually no output. In fact, one of the acronyms that's become very popular in the last few years for this kind of arrests is the HOT code, where HOT stands for hypovolemia, oxygenation, tension, and tamponade. Um, those are the most common causes of traumatic cardiac arrest, and the reversible causes as well. So yeah, I lost train of thought, but you can take it back from there.
Right. And as far as the fixing go, I know for sure you got your ABCs, which actually, I take that back. XABC. That's what we learned very quickly. So any major bleeding, like you need to fix that immediately because, like you said, with a hot acronym, hypovolemia. If your patient's bleeding out, you can do chest compressions all day long, but what are you going to be circulating? Nothing. They've already lost enough. Your airway, I mean, if you want to be a hero and intubate on scene, cool, but also you can just throw it in SGA because as long as you get, I don't know, I'm not going to get into that. Um,
Yeah, that see with trauma that deserves a paragraph on its own, because well, not a lot of the time, but whenever you have an hypoxic cardiac arrest because of trauma, you're potentially looking at extremely contaminated airway with a lot of blood, broken teeth and other stuff, or you're looking at a direct trauma to the face with a compromised anatomy and a major upper airway obstruction, or you're potentially looking at inhalation burns with swelling of the upper airway. So, if you're looking at one of those scenarios, which is typically when in trauma you have a primary airway problem, then you might not be able to write that airway off with a supraglottic. You might have to look at doing salad and getting that suction in, or you might have to get access at the front of the neck.
which is totally fair. And that's the big debate I feel like of intubating in the field or not is it's a giant like, okay, but in this instant, like question mark, just because with every call we have, whether it's medical or trauma, there's always, yeah, in this case, do this, but also you could also do this. And I feel like that's where a lot of the clinical judgment occurs of, you know, especially with like the fix and go, like, yes, you could throw in an SGA, but also you should really do this. There's not really, I think, a cookie cutter. If X, then Y. Unless, I mean, you have your chest pain. If it's a STEMI, like give your nitro and aspro, et cetera, et cetera. But yeah, I mean, it's your typical XABC. Stop the bleeding immediately. And I'm not talking like they have a laceration, put a 4x4 on it. Like we're talking like arterial. We're talking like they're missing a leg. Like you need to address this immediately. Um, and make sure they have an airway. Make sure that you're bagging them. Make sure that I mean, I this is just me on the way. Get your large bore IVs. Like there are things that need to be done. Do you need to splint the leg? No. Do you need to whatever? Anyways, so yeah, there are things that like at the core of every trauma code, you need to do XABC, and that's what I learned in paramedic school. Like you hear the phrase like if you don't know what to do, do something. Don't just stand there. But I feel like with trauma codes, I mean, maybe this is just me because I'm kind of dumb sometimes, but it's, I mean, you're doing chest compressions, you got your bleeding controlled, you're breathing for them, you got your large bore IVs, and we're riding to the hospital. Like, I mean, you're doing your continuous assessments along the way, but like, uh, I mean, what? And we can get into this. We'll just go ahead and throw this in there.
I don't think it's a you problem. First of all, you're not dumb, but I don't think it's a you. I don't think it's a you problem. I think it's an algorithm and a system problem because, like you said at the beginning, it's just not something that we spend enough time learning about. We don't spend enough time training about, and in a lot of places the guidelines are not appropriately developed because, like you said, if you go down, ACLS just following the algorithm, you are absolutely correct. That's what you would end up doing. But the reality is that trauma codes should have a completely separated algorithm, which, thankfully some places do, but they should be treated as an entirely different uh, problem because it is an entirely different problem. So I feel that sense of, lack of purpose or maybe confusion is not unique to you. It's just a manifestation of how the problem is poorly addressed in our industry.
I appreciate that. Um, but yeah, your ex ABCs, and then even though the scene may be chaotic, even though there may be a lot going on, another thing I was taught early on in my paramedic clinicals was you always have 5 seconds to take a breath and look around. And we had one trauma code. This guy still undetermined of what happened, but he was on a motorcycle. Not, and then this is another big thing about trauma codes. Did a medical event cause the traumatic code, or was it just a happenstance? Whatever it is, so nobody really knows what happened. But he ran off the road. He got thrown off his bike. Um, Shoot, where was I going with that? Oh, so yeah, you have your 5 seconds to kind of look around. And I mean, granted, they called flight because we're in the middle of nowhere. Shout out to rural EMS. But yeah, the flight crew got there, and thankfully we had an extra set of hands. But like they got there and they're doing the chest compressions, they're going in for an airway, all this stuff. I kind of just looked around, and I was actually being cleared by the agency that I work at now, and the paramedic was like, he's elbow deep in doing something. And I'm not talking like I was like standing there for like a minute frozen. Like I literally just looked up and I'm kind of looking around. I was like, man, this guy took like he caught air before he landed where he's at now. So the paramedic looked up. He's like, "What are you doing?" And I was like, I'm getting a scene set up. Like, I don't, just give me 5 seconds. And so it came in clutch because when we got to the ER, they were like, well, how far did he get thrown? And my FTO, who he's really great, but he was like, and I was like, I'm gonna be honest, it was probably about maybe 100, 150 feet. And I'm not saying it like saved the understanding of what happened. I'm not saying that like made the difference and they got him back because they didn't, but it kind of it paints a clear picture. So I don't know. For me, it's like when we have those situations, just taking a step back, and part of that, like knowing what's next for this patient, as far as when you get to the ER, what are the doctors going to do? The ER doctors who have a plethora more capabilities of what we can do in the back of the ambulance. It's they're not on that call. You are, and even on your regular calls, you are the eyes and ears for that ER, for what's going to happen next for the patient. So for me, I mean, as you're addressing your ex ABC, obviously, just taking a look around. And then even if it's not a trauma code, just your trauma call in general, take a second while they're loading the patient up and bringing them to the back of the ambulance. Look at the car. Take a second and look at how tall was the height of where they fell off the roof. Your trauma calls, there's so many different types and so many different settings. But um, if they ran one time, if they ran into a house, how far did they get into the house? So many things, so many things. But taking that moment to kind of assess like your nature of illness per se, air quotes, like what happened, why could it have happened, different things like that. I don't know, that might just be me, but I feel like having that extra step to tell the ER doctor, like, I'm gonna be honest, one time it wasn't a code, but it was just a regular trauma call. Um, this guy somehow, I'm not gonna say he shot himself, but he somehow got shot to the head. As we're carrying him out the house, I took a picture of the gun. I don't know guns. I don't have a gun. Should I? I don't know. I'm not going to get into that Second Amendment. I don't know. But that way, whenever the ER doc was like, well, what was the gun? I literally just showed a picture. I was like, I don't know, man. This. So, like, little things like that. Like, do you know the gun size? And it's even little things like, I mean, I know we're not really supposed to say, like, is this an entry or an exit? But I mean, we're taught cavitation and what it looks like. So, like, with that guy, I got a 4x4. I taped it on one side because he's bleeding. Taped it on one side and I put entry question mark. Taped on the other, I said exit question mark. I don't know. It's just little things that I feel like kind of not necessarily make or break, but for your patient's next step when they get to the ER, it paints a better picture and it kind of gives like a heads up of this is what we saw. This could be important. And maybe it's something that's not important. I'm not saying you need to know like the make and model of the vehicle. Like it's a car or it's a truck, it's an SUV, it's an RV. I don't know. Whatever it is. That might just be me. I don't know.
No, I mean, particularly when it comes to traumatic arrests, jumping to CPR and epinephrine is not really an approach that pays off. So getting that extra seconds to take in the scene and understand the mechanism of injury definitely brings value, especially in, we kind of touched on it already, but realistically, if you're looking at a true traumatic cardiac arrest, and we're ruling out that there's been a medical cause to bring to that traumatic event, in a true traumatic cardiac arrest, the reversible causes, they are hypovolemia, oxygenation, tension pneumo, or tamponade, and understanding what scene you're looking at and what the mechanism of injury is can also help to immediately narrow it down to the one responsible out of those four. It's probably not going to change the way you'll do your assessment and the order of intervention, but it can definitely help painting a clearer mental picture for you to be able to successfully approach that scene and that problem.
Which is why, obviously, we need to know A&P in general, your anatomy, your physiology, and stuff like that. But also the big things, because if even though like one time this lady, I mean, she caught air, she ran off the road, ran like not into a ditch, but like flew over the ditch and ran into a tree. There was nothing visible, but based on anatomy, like I helped myself mentally determine, like, okay, this much air, this much, I'm not good at physics, but like the mass, velocity, force, all that stuff. Like my girl had a lot of force and acceleration going on into this tree. And thankfully she was wearing a seatbelt, but like what could possibly be going on? She probably, what she did, she might have a torn aorta. She might have this, that, and the other. So like, I mean, I can't perform surgery in the back, but I sure as heck can understand that like there's a lot of internal things going on. Even as far as like, I mean, she didn't have it, but listening to breath sounds, because if there's something like that, rupturing a lung, you can do a needle D in the field. That guy, the motorcycle wreck, we had the flight team with us, so there's a lot. I had some free hands. I did needle D's. I mean, like bilateral. Granted,
Yep.
when I went for the first one, I'm not gonna lie, it was my first one ever. So I went for it, I did it, and I watched like blood start just like pouring out of it. And I looked up at the flight medic and I was like, hey man, I'm not gonna lie, this was my first one. Did I do it right? And he looked down, he's like, oh, that's not good. And I was like, me? He's like, nah, for this guy. So I did it on the other side too, because from what I was told, trauma codes, not, I would say not as far as medicine goes, but as far as interventions, kitchen sink. No, like don't go so much as like things that really aren't indicated. But you, eh, like I said, we can't see the inside of this patient unless your agency has like ultrasound and stuff like that. You should be prioritizing other things over that. But I mean, if you want to do bilateral needle D's, I'm not saying you shouldn't, but like for this guy, I went in for the other side and it did the same thing. And I looked at my training officer. I was like, "Hey, man, I don't know." He's like, "No, no, like you're in the right place. You know, the we can now ventilate better." But oh man, I was like, "Okay, cool." So yeah, there's
No, but bilateral needle Ds are definitely a standard. Like they're definitely indicated in every traumatic arrest, and it goes back to that auth arrest, right? If you are an LS provider, you should prioritize doing bilateral needle Ds over CPR, and that's a concept that we struggle with as paramedics because it's ingrained in your EMT and paramedics pre-hospital providers at any level. It's ingrained that as soon as there's vital signs absent, somebody has to be on the chest. Well, guess what? If you're on the chest and the patient has lost their entire volume of blood on the floor or inside their own body, that heart is not receiving any preload. And in fact, evidence shows that CPR in hypovolemic states does not generate the same benefits as CPR in normal volemic states. So that's your first one. And the same thing applies to a tension pneumothorax. If you have a tension pneumothorax, you have a preload issue because that tension is obstructing blood to come back to the heart. You pump that heart, you're squeezing an empty heart with CPR. All you're doing is breaking more ribs and causing more damage. So that's definitely something that should be um, talked more and I think cover more in educational programs so that we will not develop that fear of not being on the chest. Not being on the chest in a traumatic cardiac arrest at the very beginning is probably the right thing to do. You should obviously always comply with your policy and procedures, but if we look at the evidence and we look at the way they do it in the places where they do trauma codes for a living, we'll see that most of the algorithms prescribe a CPR pause of up to 2 minutes so that the multidisciplinary team can simultaneously address the hemorrhage side of things, the airway side of things for oxygenation arrest, the tension and the tamponade side of things. And then once those things are addressed, resume CPR, because at that point, you have either uh, relieve the hypovolemic state or you have removed the obstruction. So now the CPR is going to be effective. And then they proceed, they work it until they either get ROSC or they terminate based on the guidelines. But that's the way it should be.
so when you, Mike, if I'm gonna trust anybody with this answer, it's gonna be you, my guy. Um, when you get to this call, whether you know it's a trauma code or not, and say you get there and there's already CPR going, you do your look around, you do your scene size up. I'm not, and again, not talking about like going around to the entire environment, but just like getting your general picture, painting the picture in your mind of what's going on. You cover your X ABCs. Where are you going with that? Like, do you, like, if you want to run through one for me slash us, like, are you cutting close from the get go? Are you doing like you're checking for bleeding? Are you doing your airway first? Like, and then what do you do after? Like for you, and I know it's a giant question mark because every call is different, but like, what are the things you're prioritizing and you're fixing right then and there versus like what are the big things that can wait? Because again, like even just like the fix and go, your main priority is still going. It is still it's not like your cardiac arrest medically, where you need to stay, you need to do quality chest compressions, you need to actually push all these meds. And I want to get into what meds to push and what to prioritize. But um, it's so different. It is so different. So like you show up to a traumatic arrest. What are you doing? Start to finish. I mean, finish within reason, but like, what you got going on?
Yeah. Well, the first thing should be asking ourselves whether we should work that or not. And that's also always one of those things that creates problems for obvious reason. It's an extremely difficult decision to make, on your 2 feet in the field with limited resources at 3 a.m. in the morning. It's your 50th call of the 48-hour shift. So I'm not trying to downplay the heaviness of the decision, but that should be our first thing to understand. And when it comes to traumatic cardiac arrests, other than the obvious death criteria and that stuff that's more textbook slash straightforward, when clinically it goes down to two things. Uh, we should ask ourselves, are we looking at a clinically unsurvivable head injury, and how long is the downtime without a pulse for this patient? Because realistically, trauma is a disease of time. Somebody way smarter than me said that, but it's so true. Trauma is a disease of time, because all that matters is the time that you have to bring that patient to where they can get surgery and they can get blood, right? And most of the studies and the evidence show that when it's more than 10 minutes without a pulse in a traumatic cardiac arrest, the outcome is very poor. So basically, other than the obvious tech criteria and the stuff that we normally look at, that's the two things that I think should be like a decision point at the very beginning. Are we looking at devastating head injury that is completely futile to work? And how far are we from the hospital? And does the time fit or not into what is our traumatic cardiac arrest protocol? And then based on that, we're going to work it or not. If we do work it, the things that we should prioritize on scene are hemorrhage control, particularly external. So we should get tourniquets on, we should get pelvic binders on, have a very low threshold for applying pelvic binders in any trauma case. It's one of the few interventions that has no complications and no downsides. So just slap the binder on, plug the holes with tourniquets or with pressure bandages, get access, don't mess with IVs, get IOs right away, and then just start pumping. Ideally, blood and broad products. The reality is that most of us won't have that luxury in a civilian pre-hospital environment. So unfortunately, past the water, it is. And hopefully the time is short that can just be a bridge to blood products. So hemorrhage is taken care of, or X is taken care of, whatever letter version of the algorithm we want to use. Then a definitive airway, whether it's an SGA, if it's an uncomplicated airway, if it's just a matter of getting an airway and there's no airway trauma, there's no inhalation burns, and SGA is probably fine. If you can get a tube in without wasting time, get a tube in. If you need the front and neck access for those severe maxillofacial trauma or inhalation burns, that bilateral needle decompressions, even better bilateral finger thoracotomies. And then last but not least, get a look with ultrasound to the heart. And you can do that with compressions going to, if you have enough skill and training, and get a sense for that, whether or not you have a pericardial tamp or not. And realistically, the ultrasound part, it's something you can do in the ambulance. So I would say once you've controlled all the hemorrhages and you start pushing fluids, you got a definitive airway and you got your bilateral needle Ds. If you have the criteria to warrant continuing working it, get on the move then, and start CPR at that point. It's a complicated matter because, again, the evidence and the physiology, as far as CPR goes, the evidence and the physiology show that it's pretty much pointless. But majority of the algorithms out there are probably prescribing people to do CPR, even just from a legal coverage perspective. For pre-hospital providers, I would say it is possible to stop hemorrhages, even if it's not ideal because blood is going to be pumped out as CPR happens. But you can do hemorrhage control while CPR is happening. You can get an airway. You can do bilateral needle D's while CPR is happening if you train that. That is, either way, once those three things are done, then that's the time to move, because again, the things that matter the most is getting the patient to definitive care. While you're on the way, you should get those views with ultrasound, ideally, if you have the capability and you can do it. Get a sense of whether you got blood in the abdomen, blood in the pericardium, and that's it. Early activation of the trauma team at the hospital, fundamental. They'll need that blood out of the bank. They'll need to warm it up, and yeah, I feel that would be my order of priority.
Something I want to hit on that you talked about is the workable slash non-workable, because it's hard when, maybe this is just me, it's hard whenever you get to these calls, and at least for us, hopefully, we have like where I work at, we have our volunteer firefighters who, some of them are really fantastic. Some of them, I on these cardiac arrest and trauma arrests and stuff like that, I'm hoping when we show up that these firefighters are there, because I know that they'll actually help me in the back. Um, but then some other ones, I appreciate our volunteer firefighters, but they just, when it comes down to it, they don't know better. So we could get there and they're doing chest compressions on this non-workable, nothing we can do for them, nothing the hospital can do for them, patients. And it's hard because it's like, it's a patient and it's in our innate instinct to, oh, it's a patient, they're coded, we need to work them, we need to go. But there are these instances where there's, like I said, there's nothing that can be done. And you have your obvious ones like decapitation. Um, just like you talk about, those things that like they've been down for X amount of time, like nobody's getting them back. One that I had one time, the guy was in PEA, but I mean, we didn't know how long he'd been down. Just he looked fine when we first like walked up to the guy, but we roll him over to get him onto the back of this, like to get him on the stretcher. And like, I mean, not trying to be super graphic for my people who can't handle it, but this is an EMS podcast. Like the back of his head just looked like it just exploded. So like, there's nothing. Appreciate the guy for trying, but like it's just his body is going, but there's nobody that ever is going to be home again, like mentally. So um, I know you have your basic things that aren't workable, but what are like the big criteria for what is workable slash what is something that we're not going to get them back? Because even in this standard textbook, workable slash non-workable, what I struggle with is like, yes, this is a quote unquote workable arrest, but we all know we're not getting this guy back. Like the guy that got ejected off the motorcycle, our agency and our protocol, the firefighters were there when he lost a pulse, supposedly. So they started CPR. So at least for us, like he didn't look like he wasn't workable. So we had to work him and transport him. But the whole way there, like us, the flight crew that rode in with us, because they can't they can't fly in, somebody's in cardiac arrest, et cetera, et cetera. We all knew, like in the back of our minds, and it is a morbid thing, but we all know like he's not gonna make it. This guy's not gonna make it. So what is the criteria? And if you have any tips and tricks for that moment of like, yeah, we're not getting this back. And like it's kind of hard. At least for me, maybe I'm too empathetic, but what's like your do and don't list of working these traumatic arrests?
Oh, that's a loaded question. I think I like when you started talking about the the volunteer firefighters in that case, or your BLS crew working working a trauma code, and then you arriving as an intercept or as support. That is a super delicate moment, right? Because again, calling a field code is never an easy, and should not be for anybody an easy decision, let alone maybe for a volunteer firefighter or somebody that does not do this on a daily basis. So the job of BLS is to do good BLS, and it is true that BLS can call the same obvious deaths as ALS can do, but the reality of it is that if they're working it, and you get on scene, and then you understand that based on your policy and procedures and your protocols that should not be work, then the responsibility is yours to communicate that in a way that's not gonna it's not gonna offend or discredit the job of anybody. So we should do that, and at the same time, it's true that you can just work and transport something that should not be worked and transport because you don't want to hurt somebody's feelings, right? So that you need to get in that in that balance, I think. And we need to understand that transporting and working a code is a big decision, because especially if we're looking at something extremely traumatic, think about a pediatric traumatic cardiac arrest. Once you decide to transport and work that, you are making the decision of exposing a number of other people to that trauma. The trauma team that's going to receive that patient at the hospital is going to become part of that call. The family is going to potentially develop some expectations based on you transporting. So it is a decision that needs to be done with some solid criteria. And again, I can't stress enough how going by your local policy and procedure is the way to go. But from a general principle perspective, for me, the biggest things that I look at are, again, the time. How long has this been going on for, and how far are we from definitive care? um, and then the other is looking at the patient, looking at the physiology. Um, if you have a grossly evidently unsurvivable head injury, that's usually a big one that I find we struggle in calling in the field. I think that for other than the decapitations, the drownings, the electrocutions, and all that stuff, I think that the most recent evidence is showing that traumatic cardiac arrest resuscitation might be less futile than we think it is. So even for obvious chest or abdominal injury, if we are within a reasonable time frame from the hospital, and we can decompress before getting there, I think there is a benefit, especially in light of the new evidence. There is a benefit to working that, and most protocols are probably going in that direction.
I'm glad you brought up the legal aspect. This may be a bit too much, but even in a cardiac arrest, my theology is that, now granted, like, ethically, morally, I never want to leave a call or like leave a shift and feel like I didn't do enough. I mean, granted, it's bound to happen, but you know, I I always have like those what ifs and stuff like that. But especially on a legal standpoint, I don't have as big of a fear anymore, but I always have that fear in the back of my mind of being called to court because of specific calls, whether it's something I did or didn't do. And I never want to be called to court because I didn't work a patient that should have been worked. So maybe it's just me, but if it's not in that window of like workable slash non workable and like obvious death, we're XYZ, like I'm gonna just go ahead and transport. And low key, like if I get off this call, I'm just going to another one anyways. So, but in our in our interventions, in our what we can do and what we can't do, um, I want to get your opinion on as far as medications that we should and slash or should not push, because one of
I
the,
know what's coming.
one of the differences of your medical versus trauma arrest, um, and I would say this is more pre-code, but you get your patient in a traumatic event, whatever it is, just because you see the bradycardia doesn't mean for that patient in the trauma scenario you should push your atropine. Just because they have a blood pressure that doesn't look pretty, but their map is good, you shouldn't be bolusing them with pasta water. Um, and in that mindset, in your trauma codes, because if you follow the medical ACLS algorithm, you gotta get your epi 1 to 10 early on board. But I know an agency that they have taken pushing epinephrine 1 to 10,000. They took it out of those trauma arrest protocols. What are your thoughts and slash or I mean, as always, follow your local state protocols. But um what's the debate going on with that? And is that something that should be heavily thought about, or is it one of those things that like this could be a passing trend?
I think that that should definitely not be a passing trend. I think that this is something that should be discussed, and I actually don't understand how this has not happened everywhere already. Because to me, it's absolutely obvious. I mean, we talked about the reversible causes of cardiac arrest in trauma already, and none of those will get fixed by epinephrine. Realistically, the only two medicines that will fix it this are blood and steel. You know, blood and the steel of a surgeon, and 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 we kind of touched on that already. And maybe a little bit TXA, maybe a little bit of TXA, but I don't think if the cardiac arrest has already happened that TXA does any difference at that point. Um, the reality is that the most common cause of traumatic cardiac arrest is hemorrhage, and every single study out there that has studied pressors in conjunction with hemorrhagic shock has shown that pressors worsen the outcome. There is a really good review done by Fisher and others. It was published a couple of years ago, can't remember, but if you google it you'll find Dr. Andy Fisher and others, that shows very clearly the only one that might have a little bit of discussion worth having around is vasopressin, but everything else worsen outcomes. So if we take traumatic cardiac arrests for what they are, really extremely low flow state of hemorrhagic shock to the point that you're not generating output anymore, how is epinephrine good for that? How is epinephrine going to fix that, right? Epinephrine, a milligram of epinephrine is a bucket, right? It's gonna cause that heart to squeeze extra hard and extra fast. But if there is no preload, there is no point. And we are already debating on the medical side of things whether we should use epinephrine or not. And in the 2020 updates, we're stressing early epinephrine even more. While on the other side of it, we're having conversation about neurologic, intact neurologic outcome, which should really be the name of the game. And we see that epinephrine is probably creating a negative outcome when it comes to that. So yeah, I mean, go by your policy and procedures. If your medical director wants you to use epinephrine, then it's on your medical director. But from a medicine perspective, and you don't have to take my word for it because I'm nobody, but the evidence is out there for everybody to see. I'm just repeating what I've read in multiple studies.
I think it's definitely
Don't shoot at the mess.
I think it's definitely something that should be talked about because I mean, with medicine in general, from whenever dinosaurs roamed the earth and we decided to use mass pans to now, like things have significantly changed and things are always going to change. And that's the beautiful thing of the medical field because even though like you have the phrase don't fix the wheel, like we're always still wondering like how can we fix the wheel, how can we do this better, because it's not just learning more and doing better, which is it's a priority, but it's people's lives in our hands and it's making better improvements for human society, whether that's good or bad. But um and if I've definitely heard about it for cardiac arrest, but for especially for traumatic arrest, if it is something that can make or break, I would say, even one patient. I feel like it's something that should be talked about. And especially with the mindset that you mentioned, it's not an electrical reason why they've arrested. It is there's no fluid to go around. So if the like you talk about with preload, all that stuff, if there's no blood, the heart can't just push an empty supply. So I think it's definitely something that should be talked about. I like talking about it. And again, I don't know that much as you do, but I like hearing discussions about it. I like the idea that it could become a thing. So, and if nothing else, we can prioritize the other things versus I'm watching my watch and my timer and figure out like, oh, okay, well, it's time for another push of epi. Sorry, I missed the needle D right now because I had to push my epi. Otherwise, I get in trouble because protocols. Anyways, um,
Well, see, I think that that right there. It's an educational problem, right? As EMS educators, is it's way too easy to write off, the cardiac arrest part while just covering ACLS, right? But we need to remember ACLS stands for Advanced Cardiac Life Support, and in a traumatic cardiac arrest, we're talking of a completely different set of events and physiologic and pathophysiologic mechanisms. Uh, in the pre-hospital phase, like we talked about the what is the way a trauma team typically approaches this in the ER, and again, it's a trauma team with a multidisciplinary approach. And in the field as pre-hospital providers, we are kind of set with a losing ends, because there's ourselves, our partner, maybe another crew and support, but we certainly don't have an entire team that can simultaneously address all those things in a timely and orderly manner, right? We're working against chaos. We're working against the dark ditch at 3 a.m. in the morning. So um, again, from a BLS perspective, I think from pre-hospital providers, we should look at doing good BLS early and moving early so that we can get to ALS or definitive care as soon as possible, because time is what matters. And from an ALS perspective, add those that advanced airway and that bilateral needle deep, but same thing, keep moving, move fast, and get to the hospital.
absolutely. Um, and another thing I always think about, whether it's medical or trauma, any intervention, any timely matter, anything like that, always try to treat your patients like if it was someone coming for your family member, your friend, or yourself. Because at the end of the day, like these are still people's lives. Whether it, because I heard this phrase one time, and I think of this every time it's a dramatic arrest. Like, oh well, it's not me and it's not my emergency. But at the end of the day, like this is somebody's life in your hand, and maybe it's just me. Like I said earlier, I never want to leave a shift and wonder, should I have done this? Should I have worked this patient? So,
I I think you're absolutely right on that. And they always tell us err on the side of life, and this is absolutely one of those situations in which you don't want to make the wrong call. One thing that I meant to talk about, and I forgot to bring up, is the option of calling a friend. I think that I've called online medical control to terminate pretty much every single one of my medical and traumatic cardiac arrests as a civilian, other than those that I haven't worked because they weren't workable. But the ones that I started working and I terminated, I think I've called every time, even if it's not required, because why not, right? And that's an advice that I feel it's valid, right? If you're deciding to stop a resuscitation that you initiated, take that extra 3 minutes to get on the phone and run that by somebody with much more experience and training than you do, and just see if there's something that you're missing, because they might be completely on board with your decisions, and they probably will be if you're making clinically sound uh, determinations, but there might be something that you're missing. And like you said, you don't want to leave that call with that unanswered question. So that's something that I feel I strongly recommend. Get on the phone, ask your medical director, your online medical control, because why not?
it's something that I used heavily when I first started as a paramedic, and I'm not gonna lie, sometimes I still utilize this. When in doubt, call a doctor. Because there are times like when your patient doesn't fit into specific algorithms because there's so much going on. These patients are not your national registry EMTP scenarios. Like they don't have a script of what to say and for your giant differential diagnosis conclusion. Patients are very complex. So when I've gone through my protocol or I've followed XYZ steps, if I'm sitting there, I'm like, man, they're not getting better. I don't know what to do. Now, granted, you need to have the common sense and clinical judgment to understand your next three steps and think ahead. But when you come to that stumped conclusion, I'm not prideful enough to say that I haven't done it and I won't not do it, but just especially in your traumatic arrest, your cardiac arrest, whatever, but call your medical director, call your online medical control because like you said, in my phrase, it's above my pay grade.
Not
I didn't
wrong.
go to medical school. I don't have MD behind my last name and I probably never will. And that's fine with me. But
That's Matt. That's all
shout out to Matt. But
Matt.
but yeah, it's and like we talked about, it's always these giant question marks, and you can hypothetical pregame calls all day long of if this then that, and if we have this scenario then do that. But when you're in the moment, not everything goes out the window, but everything is so dynamic and changes so much. So
I think it's a lot of people have a hard time leaving the ego at the door when it comes to calling somebody, and all it takes for you to understand what a luxury it is to want to call somebody and not be able to, and then it's just like, okay, if I can, why not? And that was me in the military. Like when I started doing this kind of stuff, yeah, a lot of the time we didn't have support of medical director or a doctor to call from the field, and then you're just there on your own, and then translate it into civilian environment where I have a doctor available all the time. Like, why not? Why should I not discuss this with somebody with more knowledge than me?
and we can get into the whole topic of something very what's the word, very prominent in my life is the medic who cried wolf, especially with like not codes, with like strokes, stimmies, and stuff like that. I'm not saying you need to do it every time you see a rhythm that's funky, but I sure as heck there have been times when I call a stimmy and we get to the ER and I straight up like the first thing I tell the doc is I'm like, look, I know it's not a stimmy. I was like, but this is a left bundle that is out the wazoo. I was like, I know I may not have I probably shouldn't have called a stimmy, but I was like, this is above my pay grade. I was like, this is something that made me sweat a little bit. And all but once I've had the doctor look at me and be like, that's fine. Go ahead and call it. Now one time I didn't, but he's not a nice guy, so it didn't bother me. I didn't care. But um yeah, there's no shame in calling your medical director.
Absolutely. Absolutely. There's absolutely no shame. And even, on the topic of the STEMI, if you call a STEMI and then it turns out not to be, and this applies to a million other things along the same lines. If you're not over triaging, you're under triaging. So if you're not calling it, if you're not calling in excess, you're probably missing some. So there's that.
Do you have any
All right.
other last points, statements, anything else to add? Any advice for us in the field?
Um No, I think we covered pretty much everything. Yeah, maybe especially for those practitioners that might they might respond to a trauma code and they might not have the possibility of performing certain interventions. Thinking about blood transfusion, thinking about needle decompressions, finger tracheostomies, or whatever the case may be. Don't feel like it's a deficiency on your side. Just remember promise disease of time, so movement matters, time matters. Do what is in your scope. If you're a BLS crew, do good BLS and move towards ALS or definitive care. And ALS, do what's in your scope, and then at the hospital, hopefully they'll take care of everything else. But don't feel as a personal failure if you're in a position where you know that something needs to be done and it's not in your scope. It might happen pre-hospital in trauma, because like we said, a lot of the times surgeon is really what's needed, and we're not surgeons. It's not on us, right? Just from a little human factor perspective.
Right. Um, I don't know if you're familiar with Pokemon. The catchphrase is "Gotta catch 'em all." And as morbid this is, at the end of the day, we can't save them all. So, gotta catch them all, can't save them all. As morbid as that is, but um, Mike, if that's all you got, that's all I got. And I appreciate you coming on. I appreciate your wisdom. Thank you for your service and all that you've done in the field and in the world. And as I end every episode, so with that,
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.